In this video, we will discuss ARRIVE trial. The objective of this trial was to assess the efficacy and safety of low-dose aspirin in reducing major cardiovascular events in individuals at moderate risk of first cardiovascular event. The ARRIVE trial was randomized, double-blind, placebo-controlled, multi-center primary prevention study which included over 12,000 participants aged 55 to 80 years with a 10 to 20% 10-year risk of cardiovascular disease, but with no history of cardiovascular disease or significant bleeding disorders. And these patients were followed up for a median period of 5 years with estimated baseline 10-year risk of cardiovascular disease being 17%. The study population received either low-dose aspirin 100 mg daily or placebo. Now let's go through the eligibility criteria of this trial. Men aged 55 years or older with between 2 and 4 risk factors, or women aged 60 years or older with 3 or more risk factors with moderate cardiovascular risks were included in this study. The moderate cardiovascular risk was defined as 10 years risk of coronary artery disease of 10 to 20%. The risk factors which were considered while calculating the 10-year risk of cardiovascular disease were high cholesterol irrespective of current treatment, low HDL, current smoking or any cigarette smoking in the past 12 months, high blood pressure at baseline or receiving antihypertensive therapy, and family history of cardiovascular disease. History of a vascular event, need for an antiplatelet therapy, high risk of gastrointestinal or other bleeding, including those with history of gastric or duodenal ulcers or GI tract bleeding, need for a concomitant use of anticoagulants or frequent use of NSAIDs, and diabetic patients were the exclusion criteria. Now let's go through the efficacy endpoints of this trial. A composite outcome of time to first occurrence of confirmed myocardial infarction, unstable angina, cardiovascular death, stroke or TIA was the primary efficacy endpoint. A composite of the time to first occurrence of cardiovascular death, myocardial infarction or stroke, time to individual components of composite secondary outcome, time to first occurrence of unstable angina, time to first occurrence of transient ischemic attack, and time to and incidence of all-cause mortality were the secondary efficacy endpoints. The hemorrhagic events defined by Gusto criteria and incidence of other treatment-related adverse events were the safety endpoints. Now let's go through the outcome analysis of this trial. The intention to treat analysis and per protocol analysis were used to analyze the data obtained from the study population. The per protocol population included all eligible patients who were at least 60% compliant with the study drug during their time in the study. And the results were considered significant, and the primary objective of the study was met if the two-sided p-value was 0.05 or less. The subgroups which are used for the pre-specified subgroup analysis were age, gender, body mass index, country, smoking in past 12 months, hypertension at screening, use of antihypertensive drugs, hyperlipidemia at baseline, use of statins, cardiovascular disease risk score quantile, and treatment compliance. Now let's go through the primary and secondary efficacy endpoints. The primary efficacy endpoint occurred in 4.3% patients in aspirin group compared to 4.5% patients in placebo group in intention to treat population, while in 3.4% patients in aspirin group compared to 4.2% patients in placebo group in per protocol population. While the secondary efficacy endpoint occurred in 3.3% patients in aspirin group compared to 3.5% patients in placebo group in intention to treat population, while in 2.7% patients in aspirin group compared to 3.45% patients in placebo group in per protocol population. Thus, the primary and secondary efficacy endpoints did not differ significantly between two groups in both intention to treat and per protocol analysis. Now moving to the outcomes of other secondary efficacy endpoints. The other secondary efficacy endpoints did not differ significantly between two groups in intention to treat population. However, in per protocol population, the incidence of myocardial infarction, both total and non-fatal, were significantly lower in aspirin group compared to placebo group. While other secondary efficacy endpoints, with the exception of myocardial infarction, did not differ significantly between two groups in per protocol population. The time to the first event of non-fatal myocardial infarction was 1309 days in the aspirin group compared to 1085 days in the placebo group. Now moving to the pre-specified subgroup analysis. The subgroup analysis showed the consistent findings for primary endpoint across all subgroups with the exception of lowest cardiovascular risk quartile. Now let's go through the cumulative incidence of various endpoints according to KAPLAN-MEIER analysis. The primary outcome, secondary outcome and MI was comparatively more common in placebo group, though the p-value was not significant. While the incidence of stroke and cardiovascular death did not differ significantly between two groups, while the incidence of GI tract bleeding was more common in aspirin group. So now moving to the safety analysis of this trial. Though the overall incidence of serious adverse events was similar in both treatment groups, the incidence of clinically relevant adverse events was higher in aspirin group, predominantly because of mild GI tract bleeding events. The incidence of GI tract bleeding events was 0.97% in aspirin group compared to 0.46% in the placebo group. Though the drug-related GI bleeding was infrequently reported, it was more common in the aspirin group compared to the placebo group. Thus, the overall incidence of treatment-related adverse events was higher in aspirin group, the most common treatment-related adverse events being dyspepsia, epistaxis, GERD, and upper abdominal pain. The incidence of documented death, including fatal MI, fatal stroke, or other vascular causes, did not differ significantly between two groups. So now moving to the interpretation of this trial, though significant difference was observed in the per protocol analysis, no significant reduction in the risk of myocardial infarction was observed with aspirin in intention to treat population. In addition, aspirin did not reduce the risk of stroke and all-cause vascular death. Further, the rates of GI tract bleeding events and other minor bleeding events were as expected higher in the aspirin group. However, no significant difference in the incidence of fatal bleeding was observed between two groups. Thus, these findings of ARRIVE trial were consistent with the previous primary prevention studies. Thus, although the findings of this study were consistent with the previous primary prevention studies, the study was more representative of a low-risk population as the event rate observed was much lower than that expected, probably because of more aggressive risk factor management, and thus role of aspirin in the population at moderate risk of first cardiovascular event could not be properly addressed. Thus, to conclude, the ARRIVE trial failed to demonstrate that aspirin was superior to placebo at preventing major adverse cardiovascular events in patients at moderate risk of first cardiovascular event. So these are the references you can go through for further details. Thank you for watching.